Good afternoon. This is Dr. John Bennett in sunny Miami. We have the pleasure today of having a presentation as part of the Neurotrauma Conference. We're a little delayed, but we're very glad that these gentlemen came today to see us. We have Andrei Krassoiukov, Dr. Andrei Krassoiukov, PhD, and Aaron Phillips, PhD from University of British Columbia. They're going to talk to us about a recent publication in the Journal of Neurotrauma. The article is called Cerebral Blood Flow Responses to Autonomic Dysreflexia in Humans with Spinal Cord Injuries. Welcome, gentlemen.
Thank you, John.
Thank you so much.
Yeah, thank you for coming out today. And as I said before the show, I went to Simon Fraser, a big rival, although I think you guys are a little deeper on the science part than Simon Fraser. At any rate,
I hope so.
Okay. At any rate, it's your show. Go ahead.
John, thank you very much for the invitation. It is a great pleasure to talk about some interesting clinical research that's happening in ICORT, International Collaboration on Repair Discovery. It is the largest institute around the world with issues searching for help to people with spinal cord injury. I'm a clinician scientist. I have actually both MD and PhD in my laboratory, working for many, many years, looking on autonomic dysfunctions following spinal cord injury. And this manuscript that attracted your attention is one of the probably addressing very, very important issue in the health of people with spinal cord injury, condition known as autonomic dysreflexia. And what we're trying to do today, I will start with the clinical aspects of autonomic dysreflexia, describe this condition, present what this issue is about in a real clinical environment, and then my junior colleague, Dr. Phillips, will talk about nitty and gritty of the manuscript that just came out from the Journal of Neurotrauma. So we will start with the first slide. This is publications that we're planning to discuss. This was published, as you mentioned, in Journal of Neurotrauma. But we, as you mentioned, located in Vancouver. This is actually a picture of our institute, which is a big collaboration between clinicians and scientists. And in one building, we do both animal research, human research, and we also have a largest clinic in British Columbia, which addressing issues of people with spinal cord injury, where in one stop, patient could come and see neurosurgeon, orthopedic surgeon, physiatrist like me, urologist, pain specialist, and sexual health clinicians. It's a big advantage for us to be in this institution. That's what I will try to address in the next few slides. I will talk about complexity of autonomic nervous system, which has unfortunately disrupted following spinal cord injury. I will identify autonomic dysreflexia as a condition, how it's present, what are the possible causes for this condition, and then I also will talk about basic aspects on management of this condition before Aaron will take charge of other part of presentation. This is one of the most crucial and well-established photograph of the person with spinal cord injury who was described by Sir Ludwig Guttmann in 1947, who present a case of person who did develop autonomic dysreflexia, and one of the characteristic component of this condition is a variety of other sympathetic autonomic responses. As you can see on this picture, this person has a profuse sweating above the level of injury, which was in this case approximately at the nipple area, or T4 thoracic spinal cord injury. And this is actually sweating test was quite commonly used to detect sweating following the variety of autonomic dysfunctions. We made significant progress with respect of understanding of what is happening during the autonomic dysfunctions, but still, as you can see on this picture, the complexity of sympathetic and parasympathetic nervous system, which are innervate majority of organs in our body, and unfortunately following spinal cord injury, we see dramatic dysfunctions practically in every single organs innervated by these two systems. And we have to start somewhere. That's what I will show on this diagram. We do know that sympathetic nervous system, sympathetic preganglionic neurons, localized within the thoracolumbar region of the spinal cord. And this also accompanied by regulation from parasympathetic nervous system, which predominantly coming from above the level of spinal cord, from medulla, and present by vagal nerve. That's what we do know, that upper thoracic segments of the spinal cord involved in innervation and regulation of blood vessels in upper portion of the body and heart, and sympathetic preganglionic neurons from T6 and below segments of spinal cord involved in innervation and regulation of blood vessels in the lower part of the body and many other autonomic regulated organs. And as you can imagine, vagal nerve, which is coming out of the medulla, typically is not injured by spinal cord injury, and therefore there is a variety of autonomic dysfunctions could occur in a person depending on the level of the injury. Let's talk about the high tetraplegia. With the cervical spinal cord injury, as you can see on diagram, every single organ below the level of injury will lose supraspinal control of the sympathetic preganglionic neurons. They're still alive, they're still functioning, but they lost control from the supraspinal structures, which are both tonic and inhibitory, activate these neurons. And therefore, we do see more significant autonomic dysfunctions, including heart rate and blood vessel dysregulation in people with tetraplegia. If we look on a person with a lower thoracic spinal cord injury or mid-thoracic spinal cord injury, the severity of autonomic dysfunctions will vary because the number of sympathetic preganglionic neurons disconnected from supraspinal structures will vary from the level of the injury. And therefore, we do see quite significant autonomic dysfunction still in individuals with thoracic 6 injury, and then lower injury typically have less and less autonomic dysfunctions. This is what we do presently understand with respect of involvement autonomic nervous system in cardiovascular control. But how it translated in reality to the people with spinal cord injury? And somebody could ask me, is it really important to look on autonomic dysfunctions and particularly cardiovascular system? Yes, it is. If we look on morbidity and mortality following spinal cord injury in the last 10 years, there is a dramatic changes from previously respiratory and urogenital dysfunctions that were number cause of death of people with spinal cord injury. Presently, majority people have significant predisposition to die or develop cardiovascular circulatory dysfunctions that will be causes of mortality in this population. And therefore, it is very crucial to understand what is happening with cardiovascular control, with control of blood vessels and heart following spinal cord injury. And among these issues, autonomic dysreflexia, condition which characterized by unpredictable episodes of hypertension, which typically occur in people with spinal cord injury or people with disruption of spinal autonomic pathways, is coming to our attention. At the present time, there is an agreement among clinicians that condition of autonomic dysreflexia is characterized by unpredictable increase in arterial blood pressure from 20 to 40 millimeters of mercury systolic, and this typically occur in response of noxious, painful, or non-noxious, non-painful stimuli below the level of the injury. This is life-threatening condition, and this is a very, very crucial to remember that we have to deal and manage this condition clinically very quickly. And another very interesting aspect, what we have to remember, that typically individuals with spinal cord injury, particularly with cervical and thoracic injuries, have actually lower blood pressure than typical able-bodied individuals. On this diagram, what I will try to show you, what typically will happen during episodes of autonomic dysreflexia. We do know that most commonly autonomic dysreflexia caused by stimulation of urinary bladder or irritation of the urinary bladder. It could be kinked catheter and bladder distended, or presence of the stone, or presence of urinary tract infection. This typically will cause significant afferent stimulation, which will go to the spinal cord as any peripheral sensory stimuli. However, within this spinal cord, we do know there is interruption of descending inhibitory control to the spinal cord. And therefore, this painful afferent stimulation will result in dramatic activation of neurons below the level of injury, including sympathetic preganglionic neurons. When sympathetic preganglionic neurons are activated below the level of injury, they will result in significant peripheral autonomic responses that will include vasoconstriction and accordingly elevation in arterial blood pressure. That's why it's a nutshell how autonomic dysreflexia occurring. This is an example of the response of arterial blood pressure in a young man with spinal cord injury who underwent vibrostimulation procedure for ejaculation. This is one of the clinical methods how we're helping young men with spinal cord injury to become a father in order to assess quality of the sperm. As you can see here, at the point 1, this is a baseline arterial blood pressure of this young man before vibrostimulation procedure. Arterial blood pressure was quite low, 70/50, with heart rate of 82 beats per minute. At the moment when we start vibrostimulation, and this typically we're doing in our clinic here at the I-Cord, arterial blood pressure increased dramatically and become about 150 millimeters of systolic. At the moment of ejaculation, as you can see, point 3, arterial blood pressure went even further and reached of 240 millimeters of mercury systolic. You also can see ECG provided at that time. This young man developed arrhythmia at the same time when his blood pressure went up so high. Somebody can ask me, maybe this is a typical hypertensive response for individual who are involved in sexual activity. And unfortunately, it's not. We do have evidence that individuals with intact central nervous system during the sexual activities typically will respond with arterial blood pressure elevation by about 50 millimeters of mercury. As you can see here, individuals with spinal cord injury almost tripled his arterial blood pressure. And this is a well-established fact that sexual interaction of person with spinal cord injury typically will result in this high elevation in arterial blood pressure consistent with episode of autonomic dysreflexia. Somebody can ask, what are the possible causes and consequences of autonomic dysreflexia? And this is one of the published case by colleagues from Spain, individual who developed autonomic dysreflexia during urinary tract infection, which was attempted to be treated within the hospital, unfortunately result with intracranial hemorrhage due to uncontrolled hypertensive crisis. In my clinical practice, we also described another case where a young gentleman with episode of autonomic dysreflexia with perfectly healthy heart developed myocardial ischemia due to severe, profound peripheral vasoconstriction during uncontrolled episode of autonomic dysreflexia. And then just recently, we actually conducted reviews of all cases of autonomic dysreflexia published in the literature, and we look specifically how high arterial blood pressure will go in the cases where consequences was unfortunately death, or in cases where individual with spinal cord injury survived but still developed significant complications, including myocardial infarction, retinal detachment, seizures, or stroke, but they survived. And as you can see, there were quite noticeable difference in individuals who died as a result of autonomic dysreflexia. Blood pressure was elevated above 200. Individuals who survived from episodes of autonomic dysreflexia, blood pressure systolic reached 180 millimeters of mercury. And this data is somewhat crucial to remember because it's actually one of the recommendations of international community now, how we're managing autonomic dysreflexia depending on the level of blood pressure. And this is also will be crucial for discussion when Aaron will start his part of the talk. That's what we do know from clinical practice about people who typically will present with autonomic dysreflexia. Majority of individuals with injuries of T6 spinal segment and above typically will present with autonomic dysreflexia. And this is a reflection of the amount of sympathetic preganglionic neurons below the level of injury that are severed from the supraspinal control. We do know from clinical practice that up to 90% of people with cervical spinal cord injury could present with episodes of autonomic dysreflexia. And then we also do know that individuals with complete spinal cord injury are typically more frequently affected by this condition than individuals with incomplete spinal cord injury. But the physiology of autonomic dysreflexia is quite complex. The pathophysiology changed from the acute period to the chronic, and it's really not a topic that I could cover in a few minutes. That's why there are numerous studies at the present time demonstrated that there is a significant plasticity within the central nervous system and peripheral nervous system occurring as a result of spinal cord injury. Not only loss of descending tonic inhibition or excitation, but also dramatic aberrant plasticity of sensory afferents neurons involved in this condition. And also there is even vasculature changes occurring following spinal cord injury. And this is the latest data from my laboratory coming in this area. What are the most common causes of autonomic dysreflexia? As I mentioned to you, blood irritation, distension, bladder stone, or presence of inappropriate contraction of the detrusor bladder, considered one of the most common causes of autonomic dysreflexia. Next is a typically bowel dysfunctions, hemorrhoids, constipations are also cause significant afferent irritation and stimuli to the spinal cord. Skin irritations, and we do know that people with spinal cord injury predispose quite commonly to the pressure sores or ingrown toenails, and this simple thing sometimes could also trigger episode of autonomic dysreflexia. And finally, we as a medical community have to be aware about very crucial aspects of possible irritation and triggering autonomic dysreflexia with our medical procedures. Cystoscopy, urodynamics, colonoscopy, suctioning, and vibrostimulation that I already presented to you previously are among most common causes of these conditions. Signs and symptoms of this condition are very typically, if we do remember how our body responds to the sympathoexcitatory inputs, this is a typical presentation of autonomic dysreflexia when person has dilated pupils, flushing above the level of injury, paler color low below the level of injury because of vasoconstriction, profuse sweating due to activation of sympathetic nervous system, or goosebumps. And obviously, person who develops this condition also commonly complained on most horrific pounding headaches, nasal congestions. They will feel sometimes palpitation in the chest because typically elevated arterial blood pressure in episode of autonomic dysreflexia associated with bradycardia, and there are many other symptoms of this condition. But this is typically what will help us to diagnose and distinguish this condition. What we're doing with respect of management of these life-threatening episodes of autonomic dysreflexia. First of all, before we will start with any pharmacological agents, prevention, and prevention. We have to minimize all possible painful stimuli in a person with spinal cord injury in order to not provoke this massive sympathetic excitation that can occur in a person with spinal cord injury. However, if episode is developed, we do have, unfortunately, very limited pharmacological agents that presently are approved and recommended for management of this condition. And among them following, it is a calcium channel blocker nifedipine, it is immediate release, as bite and swallow, it is a captopril, which angiotensin converting enzyme inhibitors, also very short acting effects. And then we also use nitrates, applying either nitropase to sublingual. However, we have to be aware that all this antihypertensive medication could cause decline in arterial blood pressure in a person who already had previously low blood pressure and convert hypertensive crisis to hypotensive condition. And also we have to remember that significant number of individuals with spinal cord injury will take PDE5 inhibitors, and this is obviously contraindicated with nitrates. We do have some guidelines for management of autonomic dysreflexia, and Paralyzed Veterans of America developed guidelines for physicians and for individuals with spinal cord injury, and all actions and possible recommendation outlined there. And at the end of my talk, what I would like to conclude with, that we have to remember that there is a very good correlation between the frequency and incidence of autonomic dysreflexia in individuals with spinal cord injury depending on the level and severity. It is most commonly occur in individuals with lesion at T6 level and above. It has to be stressed and reminded that autonomic dysreflexia is a life-threatening condition and requires urgent measures. And unfortunately, we're still limited with our present pharmacological arsenal for management of episodes of autonomic dysreflexia. And one of the most common and crucial components of our intervention with this condition, it is education of the medical personnel who are dealing with people with spinal cord injury, education of caregivers, and obviously education person with spinal cord injury, what to do, how to manage, how to recognize this condition. This is the end of my talk, and I would like to transfer responsibility to continue with possible impact of autonomic dysreflexia episodes on the brain function to my junior colleague, Dr. Aaron Phillips.
Very good. Very good.
We continue?
Yes, okay, Aaron.
Perfect.
Thank you so much, Dr. K, for that great kind of introduction and background to the reasons behind and autonomic dysreflexia and the severe life-threatening consequences. Obviously, it's dear to my heart and it's a passion of mine. As one of the postdoctoral fellows in Dr. K's lab, I've benefited from his enthusiasm and appreciation for this topic. And I'd like to extend the gratitude to you, Dr. Bennett, to inviting us to participate in this conference and also participate in presenting our research to you. And we're thankful that you find it important as well.
You're very welcome.
So I'm going to start with my slides here.
Okay, there you go.
As Dr. K mentioned, I'm going to talk a lot about the details of the paper that you showed interest in, and it was entitled Cerebral Blood Flow Responses to Autonomic Dysreflexia in Humans with Spinal Cord Injury, and this came out in the past year in Journal of Neurotrauma. So we know that there's some very serious clinical issues that are related to unhealthy cerebrovascular that are common in those living with SCI. We know Dr. K just mentioned that clearly there is evidence of cerebral hemorrhage due to autonomic dysfunctions, There's also, we have evidence of posterior reversible encephalopathy syndrome occurring, but there's also subclinical issues related to cerebral vascular dysfunction that aren't overt events per se. One is that stroke risk overall is elevated 3 to 4-fold after spinal cord injury. There's also diverse cognitive dysfunctions that we know can occur in response to hypertension in the non-SCI world. And we also know that there's impaired ability to provide cerebral blood flow where and when you need it. We've shown in preclinical evidence, I showed, it just came out in the past year as well, in a T3 complete spinal cord injury rodent model, that there's impaired distensibility or increased stiffness in rodents with spinal cord injury of their middle cerebral artery, the largest artery in their brain. So this is over a range of intraluminal pressures, you're increasing the distension, and it's just not able to stretch, it's stiff. We also show that there was increased wall thickness and decreased lumen diameter of that middle cerebral artery, and this actually led to a significant increase in the wall to lumen ratio, indicating hypertrophic inward remodeling. So these arteries are getting narrower and thicker, and together this is predisposing to stroke risk. And this journal, not only was it selected as the editor's choice for the journal issue, but we were also featured on the cover. This is a middle cerebral artery here, looking at some of the sympathetic innervation density of sympathetically correlated axons. And when we looked at some of the immunohistochemistry, looking at profibrotic proteins, so collagen 1, collagen 3, elastin, we saw the significantly or substantially consistent story where the arteries in the brains of rodents with spinal cord injury have more collagen, decreased elastin, which together kind of meets the definition for profibrotic remodeling. So it's a very unhealthy state in the brains after spinal cord injury. And what are some of the consequences? What are some of the reasons for this? So in humans, it's a little bit more difficult to assess the vascular health after in the brain. So we have to have some non-invasive tools that we can use to assess whether or not the brain is healthy or a little bit less healthy. And most commonly, we look at cerebral autoregulation. Now, most people are familiar with this that are in the medical or physiology world, but essentially this theory suggests that cerebral blood flow is very well maintained over a wide range of arterial blood pressures. And once you get above that pressure threshold, you can become at risk of cerebral hemorrhage and other subclinical issues like posterior reversible encephalopathy, which I mentioned happens often after spinal cord injury. And alternatively, low blood pressure can lead to ischemic events. We know that cerebral autoregulation or the impairment of it is associated with stroke risk. We know it's related to loss of white matter integrity, and unfortunately, it's been consistently shown to be reduced after spinal cord injury. Now, you can look at this using concurrent recordings. This is beat by beat blood pressure, and this is beat by beat middle cerebral artery blood flow. And you can see that over a wide range of pressures, this non-SCI individual has very stable autoregulation. The blood flow in his brain is very consistent and very well regulated. So what is causing this significant cerebral vascular dysfunction? I mean, I hope that you can see the parallels between what I've shown is the major issues after spinal cord injury and what are some of the major issues of hypertension and the associations of impaired autoregulation. Does autonomic dysreflexia, this transient repetitive exposure to hypertension that Dr. K just described so well, does this lead to some of the cerebral vascular dysfunction that I've just shown? So this is, again, a little bit of another episode of iatrogenic autonomic dysreflexia. And you can see that as the bladder fills, arterial blood pressure drastically increases, heart rate declines. But there's not just these single massive events that lead to autonomic dysreflexia. It's not just single episodes that are very well controlled. There's actually numerous spontaneous episodes that occur on a daily basis. And we've shown that you can get up to 40 or more than 40 individual episodes of autonomic dysreflexia after spinal cord injury. And the average is around 20 times per day in people with high level spinal cord injury. So they have quite a large load of spontaneous autonomic dysreflexia that can occur every time their bladder fills up, or every time they have to go to the washroom, or even such things as sometimes even just a tight shoelace. Now on the bottom here, just out of interest, I thought I would include some of the evidence that we showed how many of these are due to bladder filling. Yeah, so over a 24-hour period, you have Botox being injected into the detrusor muscle after spinal cord injury, and you can see that it significantly reduces the frequency of these episodes. Just to highlight that as a primary consequence of this is due to bladder filling a lot of these episodes. And we just published this actually in neurotrauma as well in the past couple of months. So this is the paper that we really looked at some spontaneous episodes of autonomic dysreflexia to see how well it was tolerated. So we had a small number of subjects in this study, but this is because it was such a novel component. It's been very ethically difficult to implement inducing autonomic dysreflexia and measuring cerebral blood flow to see how well it's been maintained. So we actually were running a separate side study looking at the effects of orthostatic hypotension and a few different drugs on blood flow and blood pressure. And we thought, wow, we've actually seen a number of spontaneous episodes of dysreflexia while we've happened to have these devices recording. Why not let these tools allow us some insight into how well these guys can tolerate this hypertensive stimuli? So we were measuring blood pressure using Finapress, which is a well-validated device for measuring blood pressure. We also use transcranial Doppler of the middle cerebral artery to measure cerebral blood flow on a global level, as the middle cerebral artery provides around 80% of blood flow to the brain. And then we retroactively identified a number of episodes where we knew it was autonomic dysreflexia, and we extracted the data around these points. And you can see, just getting into the primary outcomes, is that mean arterial pressure drastically elevated during all of the dysreflexic episodes in these patients. However, the middle cerebral artery velocity was very well maintained. You can see the individual plots for each person plotted, as well as the significance value, where there was a significant increase in blood pressure, but no significant change in cerebral blood flow. Seems very well tolerated under this spontaneous scenario. And looking at just a single individual over at autonomic dysreflexic episode, if you look at the top, this is in seconds, and this is a live recording of beat by beat blood pressure over roughly 10 minutes. And you can see it's gradually elevating to a point where we had to clinically stop our protocol in order to relieve the bladder size because the dysreflexia was so severe. And when we look into the baseline portion here highlighted in gray, and then the maximum portion highlighted in gray, you can see there was a drastic elevation in blood pressure over that period of time. And these were the points of interest to us. When we looked at cerebral blood flow, however, when we take those same two time points and extract them, you can see that the profile and the appearance is quite similar under both scenarios. So they're not really having dysfunction over these gradually increasing episodes of autonomic dysreflexia. So the conclusions that we had from this study are that moderate to mild Pressor events due to autonomic dysreflexia appear to be fairly well tolerated by cerebral autoregulation. However, the caveat to this is that we don't understand where the upper limit of autoregulation is in spinal cord injury, and we also don't understand the time course of how quickly the Pressor event can take place. So not only do we not know how high blood pressure can get in this population before the brain becomes susceptible to microvascular trauma and other subclinical issues, and we also don't understand if more severe autonomic dysreflexia is traumatizing the cerebrovasculature. So to conclude, this is really providing some preliminary human data from urodynamic and PVS. We have some data now existing where we've been measuring cerebral blood flow. We finally got our ethics involved, and we showed that it was somewhat safe at these spontaneous episodes. So now we're in the vibrostimulation clinic and the urodynamic clinic, which we showed you how high blood pressure gets during those episodes and how rapidly they increase. And now we've started to evaluate how well the brain is able to buffer these rapid and large episodes of dysreflexia. And I don't want to present the data because we have a large study being prepared for submission, but it does appear as if the more rapid increases in blood pressure, as opposed to the ones I showed you that 10 minutes in duration, the ones that are 1 minute or less and are quite drastic, these are the ones that we really need to stress avoidance of, because these can lead to strokes, these can lead to hemorrhage, these can lead to microvessel trauma that leads to white matter hyperintensity issues. So these are kind of the directions that we're heading in, and we were just awarded a large 3-year grant to start assessing these things in over 60 patients. I think together, Dr. K and I would like to acknowledge all of our funding support, as well as obviously our center, which we're quite proud of, and the funding agencies of Vancouver Coastal Health Research Institute, Canadian Institute of Health Research, Rick Hansen Foundation, Rick Hansen Institute, Craig Nielsen Foundation, Heart and Stroke Foundation, and the Michael Smith Foundation for Health Research, as well as the Canadian Foundation for Innovation, who altogether support our research, as well as some private industry. And with that, I'll just take the screenshot off here, and we can discuss any questions you may have.
Sure, thank you very much, Andrei and Aaron. Excellent discussion, great slides. I'm not a neurosurgeon, and I guess the study was supposed basically to talk about the physiological changes, not really to tell doctors when to treat that pressure, the hypertension, etc. Correct?
I believe one of the aspects that we are with this study, we're validating what is already known about the danger of autonomic dysreflexia. As I mentioned to you previously, we did develop guidelines for the blood pressure measurements in people with spinal cord injury. At the present time, we universally recommend to introduce antihypertensive medication when systolic arterial blood pressure will reach 150 millimeters of mercury.
Okay.
And non-pharmacological measures become ineffective. And this is in a way based on the data that we do know about what Aaron just mentioned about general cerebral autoregulation, and then somewhat consistent with the data from cases published with spinal cord injury, individuals who develop significant negative consequences with episodes of autonomic dysreflexia. That majority of these individuals had blood pressure much, much higher than 150 millimeters of mercury. Mm-hmm. And that's why our future research that Aaron mentioned, we're trying definitely to develop further clarification and even guidelines when to start implement therapy when we're doing iatrogenic procedure, because at the present time we do not have these guidelines. Urodynamics will be maintained and conducted in most centers right now with blood pressure monitoring, but there is no specific directions at which blood pressure you should probably stop or change your procedure. And this is one of the aspects that we're trying to put forward with this research. Mm-hmm. Aaron, would you like to add something?
No, I think generally the idea behind this is exactly what Dr. K suggested. And I mean, this study is really, and in the direction of this study is really grounded in our center's unique advantage, where we are in daily communication, regular communication with some of the frontline physicians that are performing the vibrostimulation and performing some of the urodynamic filling, where we're going for coffee to discuss our work, and we're saying, how do you know when is a good time for blood pressure to start being maintained, or when do you think that you need to slow down or cessate the procedure? And the reality that I was hearing is that we're really unsure, and we need these tools. So we started to work on how can we start to answer this question. And now we've shown you kind of part A, and we're going into part B now, which is to start developing evidence-based guidelines to prevent the microvascular trauma to the brain and to prevent the overt cerebrovascular consequences.
Mm-hmm. Now, one thing, I'm not a neurosurgeon, but one thing I've been impressed with from talking to so many neurosurgeons over the last couple of weeks is that really not much has changed in the area of neurotrauma. It's kind of like, let the body recover on its own and just sustain. And this is a question mostly for Andrei, because you're a young guy, Aaron. Andrei, you've been around the field for a while. Have you seen a great improvement in the tools to measure various parameters involved in studies like yours? Or you say there's just a small improvement of the tools?
Yeah. I believe I somewhat agree with you with the general concept that we've done a lot and we don't see dramatic changes with what we would love to see, for example, with regeneration, what we'd love to see with recovery. But at the same time, in the last 15 to 20 years in the area of spinal cord injury, we done a significant improvement in understanding where big bugs was with respect of what we should change right now. We are working still on regeneration. We have some promising data in animals models, but still we don't see significant impact on the humans. At the same time, in the last 10, 15 years, we did a significant improvement in the quality of medical care for people with spinal cord injuries that did increase longevity, did change mortality pattern. One of the examples is bladder care. About 15 years ago, majority of our patients died because of renal failure, because we did not know how to manage urinary bladder. It changed dramatically. Introduction of intermittent catheterization, introduction of regular and proper bladder care, put renal failure on the back burner with respect of causes of death among of people with spinal cord injury. But at the same time, what we just showed to you, the new issue is arriving. Right now, our patients living longer, and we see new challenge. They're dying younger from cardiovascular disease, much younger than individuals without spinal cord injury. And we unfortunately still do not have this magic pill or magic intervention, even though numerous laboratories around the world are working on these issues to help with these issues. Another aspect I would like to mention that in the last 10 years probably, we changed dramatically our attitude, and it was based mostly on understanding what people with spinal cord injury want. If about 15 years ago you will ask me or any basic scientist or clinician, what will be a priority in a person with spinal cord injury or in your priority in order to help a person with spinal cord injury? And response 15 years ago, cure paralysis. This was our major goal in this population. Interestingly, in the last 10 years, due to significant input and collaboration with community of people with spinal cord injury, we learned that majority of people with spinal cord injury after 1 or 2 or 3 years being paralyzed suddenly recognize that I used to paralysis, I used to my wheelchair, but what I would love to see from medical community, if somebody will return me my bladder function, my bowel function, my sexual function, or manage my autonomic dysreflexia. And this issue is actually amongst the number 1 for people with spinal cord injury, depending on their levels. And this is definitely new perspective for many basic scientists and clinicians, that autonomic dysfunctions after spinal cord injury become somewhat priority for people with this horrifying condition. There are definitely some interesting challenges and some interesting perspective occurred during the last 10 years.
Well, I don't know if you gentlemen have any experience with patients that have used exoskeletons. Do you have much experience with patients that have used those to get around and to move?
It's a good question. Our institution and my hospital has 2 of these pieces of equipment. And this is one of the, I believe, latest advances in technologies that we as a clinician scientists still have to understand how it's helping to our patients, what is advantages, what disadvantages.
Right.
There are numerous laboratories around the world right now working on understanding what is happening. Aaron and I, just a few days ago, were at the largest Congress of Spinal Cord Injury known as ASIA, American Spinal Injury Association. And a big parts of the studies and presentations at this meeting were about robotics and as exoskeleton interventions. And one of the aspects which is obviously very interesting for us to see how this is equipment actually helping with cardiovascular health.
Yes.
But still studies are still only coming out. It's still quite early.
Yeah, well, sort of in all parts of medicine, as a physician, you're kind of taught to get the person out of bed for, for reasons of just getting the blood circulating, stopping ulcers, et cetera, et cetera. And as far as applying to people with spinal cord injury, I was just kind of wondering how that would affect someone that's active with an exoskeleton. Would it change the variables of the autonomic dysreflexia and the other types of problems they have, or would it have no effect whatsoever? But I imagine there'll probably be studies looking at that, probably, don't you think?
Well, we're kind of, at least from a preclinical perspective of cardiovascular stability, our lab is probably one of the leaders in this area.
Really?
The evidence is mainly limited right now, at least for early mobilization,
Right.
to the preclinical evidence in terms of autonomic function. We're not using exoskeletons per se, but this analogous kind of technology for rodents was a small, tiny passive exercise bicycle.
Right.
We've shown that if we start exercise as early, it has to be early initiation though. If we can start exercise within 7 days after their transection, where we simulate a high thoracic cervical level spinal cord injury, we can not only we know that we can prevent the autonomic dysfunction, or at least reduce the severity significantly, but we've done a lot of work unraveling or unwrapping the mechanisms behind this. So we know, I won't get into all the neuroanatomical changes that occur after spinal cord injury, but many of the subtle things in the dorsal root, as well as some of the plasticity intraspinally, these pathways that Dr. K demonstrated, we can reverse those aberrant plastic changes. So not only is resting blood pressure a little bit higher and a little bit more stable in these rodents that initiate this and have the aberrant plasticity prevented, but their dysreflexia severity is significantly reduced. Now, the most important component of this that we're trying to translate into the clinical population, and we have some ongoing work in this, is it has to be initiated early. If you do it later, even 7 days versus 3 weeks, the plastic changes have already occurred and they're very difficult to mitigate once it's occurred. So it has to be initiated early. And I think Dr. K is at the front lines involved in the subacute rehabilitation. And I think there's already over the years become an emphasis on even more early mobilization, because they're starting to realize, although maybe not in the same quantitative way, the empirical evidence, but the clinicians are noticing over time that this is having a much better result.
Mm-hmm. Very good. What are you gentlemen going to do for the next year or so?
Where to start? Do we have another hour?
Oh, okay. Well, you're certainly welcome to come on anytime.
Yeah.
You guys are great, even though you're from University of British Columbia. I'd still like to have you back on again whenever you guys have something new to report, because certainly it's an area where most doctors feel that, that it needs a lot of work, and it's certainly worth studies and investigation as well. There's other areas of medicine that most doctors, they like to discover occult cancers early. These are two areas I think most physicians really like to see improvement. There's spinal cord injuries and occult cancers. And hopefully all the digitalization and improvements in devices and early detection will improve both areas. So I'd like to thank you, gentlemen, and we hope to have you on soon.
Okay, thank you so much for the invitation.
Thank you, John, again. It was a pleasure.
Thank you.
Bye-bye.